Hello and welcome to 30 Minutes. I'm Rick Anthony. The subject of today's discourse is the state of healthcare in the United States. But first, a nostalgic look back. There was a time not too very long ago when doctors actually made house calls. In my case, our family physician was Dr. Heisman. His office was in his home a few blocks away, up on the avenue. At the time, it seemed that Dr. Heisman could fix anything, and in most cases he did. You didn't have to go to the pharmacy because Dr. Heisman sent you away with the pills you needed in a little white or brown envelope. And if you couldn't get to him, Dr. Heisman came to you, clutching his little satchel, a little black bag, as universal a sign of medicine as caduceus, the symbol of medicine, is in the United States today. Dr. Heisman is gone now, and with him are the thousands of others like him who dispense the kind of health care, the kind of caring treatment that we all wish we had today. Which brings me to today's guest, Dr. Frank Speidel, who is the author of a book he's working on, the title of which is Healthcare in the U.S., Dancing Beneath the Diamond Sky, a thought-provoking reflection on his long career and lessons learned as a CEO, Chief Medical Officer, Chief Quality Officer, Compliance Officer, Privacy Officer, member of the Medical Executive Committee, and Department Chair with large health systems as well as standalone hospitals, and a forward deployed operational military unit when he was in the Navy. Dr. Speidel has an undergraduate degree in physics, an MD from Temple University School of Medicine, and an MBA from the Wharton School in Finance and Information Systems. He is currently executive in residence for healthcare at LeBeau College of Business at Drexel University. And most impressive of all, Frank and I have a connection to Frackville, Pennsylvania, a small coal town upstate where I was born, and Frank's grandfather worked in the mines. That was a long intro, Frank, but it was worth every minute of it, I think, to give you folks the full flavor of who you are, your background, as they begin to understand the mission you have in writing this book. Welcome to 30 Minutes here at Radnor Studio 21. I know your book is still in manuscript stage, but if the introduction and the chapter reviews that I read are any indication, you take your profession, your fellow professionals, to task. One example in chapter 17, you refer to certain surgeons as white-coated simians of surgery. I love the alliteration. And in chapter 29, you ask, are there themes that resonate in healthcare? More importantly, do these themes invite intervention? Does the individual have meaning in the massive machine that is U.S. healthcare? That's pretty tough stuff.
It is. And thank you for having me, Rick. I love talking about healthcare. There's sort of recurring themes that I've noticed over the years. I think all of us would agree right now. Few would disagree with the concept that we're not satisfied with healthcare we experience today in the United States. And we hit the usual suspects. We attack cost, we're concerned about availability and the quality of care. There are no shortage of passionately advocated solutions for this, some of which have been tried, and many of which have been tried and don't work and are disastrous. Another concept that I want to share with you today and share with our audience is that I think that improving healthcare, improving what we experience here in the United States, is best done after a ruthless examination of many concepts that we have become quite comfortable with. Healthy skepticism about things we know to be true that probably aren't. The other thing is that healthcare, I've seen it my whole career, is a dynamic, complex, nonlinear, unstable, inconsistent system. It's the kind of thing that when people who don't have a lot of experience start pushing on the buttons and changing things, getting involved in it with the best of intentions, they can cause catastrophes. Just this past week, I don't know if it caught your eye, but Massachusetts is considering legislation that would mandate staffing ratios for nurses. It's something that seems like a good idea. I mean, we all could use more nurses. But the challenge of that is that there's only a finite number of dollars in the healthcare kitty. And you've got to try to balance it out between differing degrees of care providers. And when you start having somebody on the outside picking ratios for staffing, you hurt your flexibility, and it's a challenge. It doesn't, well intended, but it doesn't get you where you wanted to go. Now, the other thing that I found fascinating was you picked up on Chapter 17. That's a situation that
those the simian surgeons?
The simians, the surgeons, simians in white coats. People make mistakes. It's human. That's what we do. We do things right a lot of times. We have good intentions, but we can make mistakes. The challenge, the difficulty is, and where we lose it, is when we are refusing to examine our mistakes and understand it's not a judgment of us as an individual. We're looking at it to find ways we can fix it and improve. The case that that chapter is about a surgeon who ordered a CAT scan for appendicitis on a patient he was asked to see in the emergency department. The CAT scan for appendicitis was negative. The surgeon was aware of that and took the patient to the operating room and removed a perfectly good appendix.
Just for good practice?
I think that it was. You can do that.
Yeah.
If you clinically suspect the patient has an acute appendix, it's not just one lab study. It's the whole picture you have to judge on, and that's understandable. We've all been there and used our best clinical judgment and ignored the laboratory study. With the normal appendix, reasonably, this was a young person. Reasonably, the parents wanted to know what happened. Why, when you had a negative CAT scan, did you take our daughter's appendix out? He refused to talk to the family because his advice that he received from an attorney was, don't talk about the case until you get deposed. There was no threat of a suit. He was just told not to talk about it. That's one thing. But the other challenging thing about it was when it went for review by the quality department and the surgical department, they found that there was no breach of the standard of care, which could be perfectly consistent, but there was no documentation to it. And the approach was doctors don't make mistakes. And you're never going to fix it unless you're willing to confront head on that you're human.
It sounds like all of this has been bubbling up for a very long time. Now that you are almost retired, are you taking advantage of the time to now put onto paper everything you've thought, every feeling you've had, every conclusion you've come to? Is that what you're trying to do?
How can I not? Nowadays, if you're alive and aware of what's happening around you, you'll see, I've seen a collection of bad ideas that reflect the worst thinking of 18th century economics become alive and well in our delivery of health care in the United States. In fact, they've been enshrined as boilerplate, some of these bad ideas.
How did the title come about? The first part I understand, healthcare in the United States, but the, what is it called? Dancing Beneath the Diamond Sky? What's the story behind that?
I stole it. I stole it from a Nobel laureate literature winner, Bob Dylan. Mr. Tambourine Man. Okay, there's a line in there where he talks about far from the twisted reach of crazy sorrow, to dance beneath the diamond sky with one hand waving free. Rick, when medicine is at its best, that's what it does. We take our patients from the twisted reach of crazy sorrow and we let them dance beneath the diamond sky with our hands waving in the air. That's when medicine is really good, when it's doing what it's meant to do.
But you're one person, one professional, one of them. What do you hope to accomplish with the book?
I want people to start talking about it without the cliches. I want them to look and see newly, examine ruthlessly these concepts that we've become so passionately attached to with no real good basis.
In the book, based on the chapter previews that I read, there seem to be three elements. There are many more, but three principles. One is cost, the other is quality, and the other, as you were beginning to touch on earlier, is the correlation between cost and quality, and what are the trade-offs. Is that correct? Is that
absolutely?
On cost, talk about cost. Real cost.
Real cost. About in the late 90s, there was a front page article of the Wall Street Journal celebrating a triumph of the U.S. capitalistic system and economy. World Wrestling Experience or Entertainment, McMahon's company, in 1 year doubled its sales. And this is a success. This is the way things are. Well, what McMahon did, he had a product that people liked, and he sold more of it. Now, right now, as we're in the campaign season, you cannot listen to an ad without hearing something about constraining the cost of health care.
Yes.
How do I square these two? That if health care goes up more than the growth of the GDP, greater than 4%, it's a crisis. But if an industry produces more of a product that people want, that's a success.
Yeah, but now we have to talk about what is the real cost.
Well,
And I'm not an economist, but
okay.
as you know, that's part of the debate. For example, prescriptions. What's the real cost of prescriptions? And why is it that we in the U.S. pay more for the same product that is available to people outside of this country at a lower cost?
It's because
a lower price, I should say, not cost.
Yeah. It's the answer to that is because it's a classic economic concept where if you can break the market down into segments that don't communicate, an overseas segment, and I can sell X number at this price, and I have a captured market, domestic market, where I can have a higher price to optimize for the company to optimize its return on revenue, to optimize its return, it's going to segment the prices at different markets. But let me go back.
But it's also spawned a new industry, and
Pardon?
that is, it's also spawned that condition, that circumstance, a new industry, because the cheaper drugs are coming back into this country
Right.
at a lower cost.
Yes, and they have to be. It's kind of like an arbitrage system where we try to accommodate different prices. But let me go back for a second to talking about cost in aggregate.
Okay.
We were aware that cost of healthcare is going up. Healthcare is going up, and we're getting a different result. If I said to you, Rick, I'm going to sell you a car for $40,000, would you buy that car?
It depends.
Depends on what?
It depends on whether or not I need a $40,000 car, whether or not there are other options available to me,
Right.
whether or not I want that particular car for $40,000. It depends on a number of variables.
So if I want to sell you my brother-in-law's truck that's got 220,000 miles on it for $40,000, the answer is probably going to be no. But if I get you a Lamborghini right off the line, that is worth the $40,000.
We can do a deal.
So when we talk about just the cost of healthcare, we're only talking half the equation. What do I get for my healthcare expenditure? And I will argue, I can show you a couple things. The first thing I can show you is that the costs are increasing, but the market basket of goods is not the same as it was back in 1980, specifically. 1980, newly minted resident working in a community hospital. I had a young man in his early 40s come in, and right in front of me, die of an aneuryseptal, a big front part of his heart attack, where he took out the whole front wall of his heart. The good Lord was kind. I had a wonderful cardiologist with me when this man showed up, and over 2 hours, there was nothing that we could do to change what was happening. Dial the clock forward, 2012. I'm in the hospital down in Houston. We have a primary interventional cardiac cath lab, and this is something that's just happened in the last 10 to 15 years. Nothing like this was available in 1980. He comes in, exact same cardiogram, exact same pattern, a young guy in his 40s. He ends up getting rushed to the cath lab, and in less than 60 minutes, the cardiologist, the interventional cardiologist, gets the catheter in, puts the balloon across the lesion, gets rid of the clot, dilates the vessel, puts a stent in. The next day, I'm talking to him at 11 o'clock in the morning. This man is going home later that afternoon. Same diagnosis, acute myocardial infarction, entirely different results. And one of the slides you'll see that the cardiovascular mortality in the United States has just been going down continually. And it's not just cardiovascular mortality. We are having improvements in cancer care. Well, that's happening in Europe too. Well, it is, but not to the degree it is here. And if you look at comparisons, you'll see that our acceleration in spending on healthcare is paralleled by the developed world's acceleration in spending on healthcare. The difference is that when you do studies, if you compare two groups, the groups have to be kind of identical. We superficially think that our society is a lot like France or England. Different. Just look at homicide deaths. If you look at homicide deaths in the United States, they're massive compared to the developed world. Look at immunization rates. We are different cultures. We trying to compare. And the other thing is, too, American expectations are much higher than Europeans. A good friend, is a Canadian, had to wait 20 months for an elective hip replacement. Americans tend to be a bit impatient and expect to have better things, better food, better football teams, and better health care.
I can't disagree with everything you've said based on my ignorance or out of my ignorance. However, why is the cost of health care, why is the cost of education as well, but that's another story, accelerating at a higher rate than the cost of living?
The same reason as
when you look at the charts, as you know, healthcare is going up like that. Cost of living is down here.
Yes. One of the things that drives it, it's the same thing that drives how much we spend on personal electronic devices. There is a collective choice by society. I want to have my iTunes available 24/7. I want to have the Stone Cold Steve Austin experience of World Wrestling Federation. I want to experience that. This is driven by the population's expectations. We no longer accept that when I have a heart attack, I'm going to die. We think, well, just think about it. Right now in politics, we go back to this campaign. People will make a campaign issue, we've got to control the cost of health care. At the same time, the politician will say, and no particular politician, will say, we need to spend more on education. You know, our test scores aren't improving. You'll see that on one of the slides. They're pretty flat. But healthcare, we're making a difference, and it's because we are spending more money.
Okay, which takes me to my favorite subject. Every day in the mail, the U.S. mail, there are solicitations from any number of organizations fighting cancer, Alzheimer's disease, you name it, and there's a campaign for it, at least one campaign for it. With all the money that's been spent and is being spent and will continue to be spent, federal dollars, private funding, and so on, why aren't we any closer to finding the cure for cancer? And I asked another doctor this one time, he gave me an answer. Or finding a cure for any of the other diseases. Now, to your point earlier, however, the incidence of cardiovascular or death as a result of cardiovascular disease is going down because of technology largely and the new techniques. I'm a beneficiary of that with 5 stents. But what about the others? Cancer, for example. Have we made a dent as a result of all the research in cancer?
One of the
Even
slides,
a dent?
One of the slides will show you that that our deaths due to cancer, the incidence is going down. And one of the other slides I have in there, it compares survival rates in the U.S.
Yeah,
Go ahead.
It may be going down, but what about the quality of life? Because the treatments are horrific, as you know much better than I. Chemotherapy, it's horrific.
Rick, be of good cheer. When I was growing up in medicine, if you had non-Hodgkin's lymphoma, that was a death sentence. You had 3 to 5 years. Not anymore. One of my best friends is about 15 years out from a non-Hodgkin's lymphoma. When I was growing up in medicine, if you had hepatitis C and you ended up in liver failure, your treatment was what? It was a liver transplant. Not a good quality of life. We have antivirals now that cure people, serologically cure them of hepatitis C. This is an incredibly exciting time. There's some great work being just done here in Philadelphia, down at the University of Pennsylvania, with something called CAR T therapy. We are curing metastatic cancer with it. It's very expensive, but we are making a difference in the oncologic world. It's expensive, but where else are you going to spend your money?
No. You are, by virtue of your education as well as your experience, you are an expert in information technology and the application of IT technology. to healthcare. Why hasn't the promise of technology been realized in healthcare, at least according to much of what I've heard and read? There's still roads to be traveled.
Let me give you a little background on that. We had high expectations. For a long time, it's been appealing to think, we have this powerful machine that can do all this and store vast amounts of information. Why don't we harness it to taking care of people that are sick? And that's very appealing. And that is going to be the genie that really, really sets us free. That is going to be the gift of fire to healthcare, that we learn how to use it. Back in 2005, there was a RAND study that came to the conclusion that you could save $80 billion a year in healthcare. Now, right now, we spend about 3.4 trillion, or about 17% of our GDP, is spent in healthcare. But you could save $80 billion a year in healthcare expenses if we had good IT systems. Unfortunately, as you know, and we've seen this firsthand, there's just recently came out a wonderful article that demonstrated that it's just not working. It is turning the caregivers, the people at the bedside, and the nurses, the physicians, into the highest paid group of data entry clerks the world has seen.
Absolutely right.
They don't talk to you anymore.
Right.
They
have a machine.
They stare at the machine, and they're doing data entry.
Because the government requires it.
Yes, and that's one of the challenges. That what the government required was that you have a system that looks like this.
Right.
They didn't require that the system work.
Yeah, right.
It's one of these things, once again, the best of intentions. They decided to require physicians, required health systems, required all caregivers to use IT. The only problem was much of the IT that is out there was people don't use it, or they just stare at the screen.
Well, the systems don't talk to one another.
Yeah, they don't talk to one another. And one of the reasons for this is with the people that were building these systems, that were designing them, built what they thought healthcare givers would use.
Right.
They didn't look to see how the healthcare providers provide care. An ancient axiom in information technology systems design is you want to look at how people go about doing their tasks, identify decision makers, understand what data they use, take that data, turn it into information to help them make it.
Yeah.
Instead, I think this is the way healthcare is provided, and I'm going to build a system that gives them this. See what people use, and then build the system to support that.
And that isn't done at all by Siemens, and I don't know why that name came to mind, but the GE, all of the folks who manufacture, create, design, manufacture, and sell devices to be used in medicine to produce better outcomes. They don't talk to the people who...
Oh, they talk to them.
But
they don't, I think they talk to them, they don't listen to them. And that's a big
fair
difference.
enough. In Chapter 8, titled The Old Rheumatologist, you mentioned Dr. McGovern. Now, I don't have the benefit of the full chapter, obviously, but I was wondering, what was there about Dr. McGovern that so impressed you and that you felt that he should be emulated by other healers?
When I was a med student, I met Dr. George McGovern. He was a rheumatologist, and I was rotating on his service. He wasn't cool, Rick. He didn't have the latest New England Journal article stuffed in his pocket. He wasn't a real hip academic. Old gray-haired guy. I was making rounds with him, and he was always behind on rounds. He talked to patients a lot. He's always behind. So we're in this hospital, and it's about 6:30, 7 o'clock at night. And we're down to radiology. We're looking at films with George. And there's a lady, a very frail, porcelain, gray-haired soul, on a stretcher in this empty radiology department. Do you remember the movie George C. Scott, The Hospital? There's a character in there,
yes.
the Paraclete of Caborca, who went around murdering people or hurting them. And he took one of his victims and placed him down in radiology. And the George C. Scott system wanted to put him down radiology. He said, well, where else could a body lie for hours unattended and nobody think anything twice of it? Sure enough, that was what we experienced that night. Dr. McGovern dropped everything. That patient, he talked to her, found out she was cold, She was confused. She didn't know what floor she was from. She didn't know anything about who her doctor was. She was this poor lost soul in the middle of this very expensive health care. We dropped everything. He sent all us folks in white coats out scurrying through the hospital, trying to track her down, find out where she belonged. But the first thing he did, found out she was cold. She sent us down, one of us down, to get warm blankets. Hospitals in some spots have plots where they warm blankets. He knew where it was. This wasn't the first time he did this. That was patient-centered care.
Yeah.
Great man. He should win not the Nobel Prize in Medicine. He should win the Nobel Prize in Medicine.
Are you in favor of universal health care or a modified version of it?
That's what I hope this conversation is going to discuss, that I want to spark. We have a duty to care for each other. It's that simple. We are our brother's keeper. The best way to do that, I'm skeptical if it's going to be a single payer, centrally controlled system. Those tend not to work in my experience. We've got to find some way to include the patient in the decision-making process. I steal most of my ideas.
There are only 14 original ideas in the whole world.
I'm 3 behind. Milton Friedman wrote this wonderful book called Free to Choose, and he talked about healthcare in there. And he pointed out that if I was to buy a car for Frank Speidel, chances are I'll buy the car I want at a price I want. It's not that way in healthcare. What happens in healthcare is I'm going to buy a car for Jeffrey over there, and Karen over there is going to pay for it. Somehow we've got to include the decision makers into this process of allocating resources in healthcare. It's got to include that. It can't be just a carte blanche to everything you could possibly imagine.
Regrettably, we're running out of time. And before we go, however, I'd like to ask you to read something from the introduction to your book, a few paragraphs. And as I read them, it seemed to me they might very well be the epilogue to the book rather than part of a prologue. I think you have them there. Would you mind reading those few paragraphs as you wrote them?
Be happy to. Correct me if I drop a sentence here. Given the significance of healthcare delivery, the intensity and passion of the discussions quite reasonably follows, as they should. I celebrated the involved debate and dialogue about healthcare delivery. But national discourse is planted thick with pronouncement, ideas, and assertions that have no, or at best inconsequential, representations in the real world of healthcare delivery. Do you believe that improving the quality of healthcare will lower the cost of care? I don't. The aggregate cost of care. Will the use of technology lower the cost of care? Aren't we in the United States spending too much on healthcare for the quality we get? Isn't the cost of healthcare spiraling out of control? If healthcare costs aren't controlled, they will take over the GDP. If we would just invest in information technology and make doctors more computer-savvy users of IT, we would improve quality and lower costs. If healthcare providers would embrace evidence-based medicine, quality would soar. These ideas sound familiar? Aren't they comfortable solutions? But what if they're not quite true? What if they are actually the opposite? I happen to think most of these are false ideas.
And should be examined.
Yes, ruthlessly.
With that said, are you optimistic about the future of healthcare in this country?
Absolutely. I've had a front row seat. I've seen this for the past 40 years. The changes that I have witnessed for the better. There was a time when talking to patients and being honest with patients was not valued. It's different now. We teach that. We do it wonderfully. What we could offer people with an acute heart attack changed massively.
Yes.
People with, as I said, many cancers, we had no options. People with horrible infectious diseases, we had no options. It soared. And the best part about the future of healthcare is I get to talk to young people going into healthcare. And these people are bright, enthused, and passionate about healthcare. How can you not like our future?
Well, happy to end on an upbeat note. Thank you very, very much
Thank
for being
you,
here.
Rick.
I appreciate it very
appreciate
much. Best of luck with the book, Healthcare in the U.S., Dancing Beneath the Diamond Sky. And thank you for watching this episode of 30 Minutes at Radnor Studio 21. I'm your host, Rick Anthony. Until next time, take very good care of yourselves.